Good morning. Today's a special day for us at Seattle Children's for many reasons, but one of the most important is our guest speaker today, Dr. Chris Feudtner. Dr. Feudtner is a former member of our faculty and a national leader, and we're very excited to have him back today and for tomorrow's fellowship research day that will be down at our Research Building 1 during the day tomorrow. We've had a record number of abstract presentations. I hope those of you that can come down and support the fellows will do that. Dr. Feudtner received his undergraduate degree at Princeton, and as you can see, he's been a perpetual student, and he has a very large letterhead. He had to get an extension of his business card for all his degrees. He received a master's degree in England and Lancaster University. He's a graduate of the University of Pennsylvania Medical School, where he also received a PhD. He got his real education here in Seattle, where he received his Master's of Public Health as a Robert Wood Johnson Scholar. Following his residency, Chris was a resident when I arrived in 1996. He joined our faculty in 2000 and was here with us for 2 years before returning to both his academic home and his family's home in Pennsylvania at the Children's Hospital of Philadelphia. He currently is in the Division of General Pediatrics and Director of the Department of Medical Ethics at CHOP, one of the premier pediatric institutions in the world. He also is Fellowship Director of the General Pediatrics NRSA Award. Chris, I think to talk about what an important influence he had in our department, one of the most prestigious awards that is given by our Department of Pediatrics is the Stanley Stam Role Model Award. And although he was only here for 2 years, Dr. Feudtner was elected by the residents as a recipient of the Stanley Stam Award, which is an incredible compliment and testimony to the kind of person that Chris is. He has published 150 papers, chapters, and he's written 2 books, one entitled Bittersweet, A History of the Joslin Diabetes Center, which is on my shelf, Chris, thanks to you. And when you look at his CV, among his first publication was in 1993 with someone named Dimitri Christakis. And they were both medical students at the University of Pennsylvania, and it's entitled Ethics in a Short White Coat. I'd like to see Dr. Christakis in a short white coat. Chris, it is really an honor to have you here today, and we're looking forward to you spending a couple of days. Thanks.
Well, thank you for inviting me. I have no conflict of interest to declare, except that I do have to feed and water these 3. I want to start out with what I take to be a mysterious observation and tell you a little story about one of the first ethics consults we did when we started our pediatric palliative care team at CHOP 2003. The call came in one afternoon from a faculty member who said, "We need your help. There's a 4-month-old who was admitted close to 2 months ago. He had been born full term, healthy, no concerns, went home, people were thrilled, another happy baby to join the family, but he had failed to gain weight. And over the course of that first month, when he continued to fail to gain weight, they had tried the usual things and had advanced after that to actually becoming more alarmed when he continued to not gain, and had eventually admitted him. The routine tests had been done over the course of the ensuing 2-3 weeks. Again, nothing had materialized. Some labs had been sent off. And at that point, right before we were being consulted, a week before that, the news had come back in from one of the send-out labs that it was positive for one of 2 conditions. They couldn't be sure which one it was, but both of them were fatal. The family had been told that news a week before. And we were getting the consult that day because the team was stuck. They were unable to figure out how to discharge this child. He continued to sort of have this chronic low level of weight loss, so he wasn't plummeting, but he certainly wasn't gaining, and they didn't know where to go. I said, well, thank you so much for the consult. How about we have a family meeting tomorrow? That was arranged. So the next day I showed up at the room where we were going to have it. It was a room that was large enough to accommodate quite a few people. And I walked in with my nurse, Gina Santucci, on the palliative care team, and Carolyn Long, the social worker, and we sort of sat down. And in filed the family. It was the mom and the dad at the front of the line, and they had their heads down. And behind them came both of their parents, both sets of grandparents. And after that, there was other members of the family, aunts and uncles of the child. And by the time the room was filled, there were about 9 people sitting in front of me, looking at me as we sat down. And I started out saying that I was grateful that they had come to be able to talk to us, and I was trying to think of how we could be helpful. I had heard that a week ago they had gotten very bad news, and they nodded that they had heard that news, that they knew the diagnosis, whichever one it would be, was going to be fatal. I said, as I'm sitting here trying to think of how to be helpful, it would help me take better care of your child. I'll call him Mason. It would help me take care of Mason. If you could tell me, given what he's up against, what are you hoping for? There was silence. And the mom sort of looked at me and said, with almost a laugh, well, I'm hoping this is all just a bad dream. I wake up every day hoping that this is just a bad dream. I said, I wish that was what we were dealing with. What else are you guys hoping for? She drew a breath and said, well, I'm hoping we can stop torturing him, because every time we try to draw blood now, it's almost impossible. He's blown all his veins. They can't get IVs started. That is impossible at this point, and even drawing simple labs is difficult. And he cries and cries. Okay. Thank you for telling me that. What else are you guys hoping for? For the first time, the father looks up and looks at me and says, well, I'm hoping we can get the hell out of the hospital. We've been here for 2 months almost, and it's pointless. We know what's going to happen now. We just need to get home and be able to be with our family. We've got 2 other kids. They hardly know their brother. Okay, thank you for telling me that. What else are you guys hoping for? One of the grandparents sort of leaned forward and said, the baptism. Yes, we would like to baptize our son. We had been planning to do that, and he had gotten sick, admitted. We postponed it, and here we are. We haven't done that. What else are you hoping for? Dad said, I just want us to go home and be a family. I want us to be able to have time together. I said, well, thank you for sharing that. They mentioned a few other things. And there are certain things I wish we could make happen. I wish that we could make this a bad dream, that you could wake up from. There are other things you mentioned, though, that we could do something about today, like not drawing blood. And I sort of turned to the medical staff and I said, can we just stop ordering tests? No more tests. And we also, I didn't hear, just let me be clear, I didn't hear anybody say that we need Mason to gain weight. I wish we could make that happen, but I think we've come to realize that that's not something that we can do, at least not readily. Maybe we can let go of that. And if you want to go home, we can make that happen today. At which point, Gina elbowed me, there's no way we're going to be able to pull that off. But that's why I'm there, just to make life difficult. And actually, after a little bit of planning, we actually had a wonderful pediatrician in the community who was willing to actually go and do a home visit later that night. We had a hospice team in the South Jersey area where they were living who was willing to open the case. And around 7 o'clock that night, Mason left the hospital with his family, went home. He then had a baptism, which I mentioned, and had a birthday party. They actually had birthday parties every single day in order to be able to have all of the parties that they had hoped they would be able to have for him at least get underway. And 2 weeks later, when he died, with his parents holding him on the couch, they were eternally grateful that he was part of that family, had been part of that family in the home environment for 2 weeks. A year later, we got, at PACT, our palliative care team, we got a little birth announcement that the couple had had twins, Hope and Faith, because as they wrote on the card, sometimes you need a little faith to have hope. The part, though, of this story that I actually want to draw us back to, the part that I think is mysterious and is going to be the real theme of the rest of this talk, is how people after that conversation, that family meeting, had gotten up and left. They had all walked in dysthymic, very, very upset. They were looking at each other, but you could tell, hardly making eye contact. We had talked for quite a period of time. There had been a lot of emotion, a lot of tears. We had affirmed the fact that the diagnosis that their child had was lethal. And in many ways, we had done everything that would be the classic presentation of how one might, quote, take away hope or kill hope even. And yet when they stood up to leave, although they were sad, they stood up with a different type of energy, much more positive energy. They actually stood up and hugged each other. There had been tears in their eyes, but as they walked out, it was clear that they were walking out with a new sense of purpose. And I don't want to overstate this. They were not happy about what was going on, but nor were they worse than when they had entered. They were better. Now, for those of us who do palliative care, I know several of you in the audience do, or just in the intensive care units or any place in this hospital where this is one of the themes of our work, of actually having to talk to families about what lies ahead. Certain conversations are transformative, even though they're not what people had hoped for in entirety. It allowed them to start thinking that there were certain things that they could hope for and could pursue effectively. Years ago, when I was still here, I encountered Robert Pinsky's translation of Dante's Inferno. And in reading it, there's this scene. Now, in the Inferno, you may recall that Dante has lost his way, and Virgil is his guide. And Virgil, because he was born before the time of Christ, and the whole theology of it all, is cast in limbo. And he says, when they come upon limbo in the tour through hell, the underworld, he says to Dante, "We are lost, afflicted only this one way, that having no hope, we live in longing." And I remember reading that line and thinking to myself, I wonder how many of the parents that I take care of, their children, entered the hospital with a hope of cure or hope of really disease eradication, and had learned somewhere in their illness journey that that was not possible. And now they just lived in longing, unsure of what could they invest in hope-wise next. So I want to try to take what I think is a mystery, because how many of you actually have had conversations where almost when you leave, people come up to you, "What did you talk about?" Because the family seems to be better, and yet I know you're the palliative care team. Part of my career is sort of devoted to understanding how you take that mysterious sort of hard-to-fathom observation and understand the mechanism by which that might be occurring. So to do that, I want to, in the time that we have together, go through 4 different issues. One, describe a cohort study that we've done at CHOP that I think sheds some light on what might be happening, and examine through the data that we have there the effects that affect and emotion has on decision-making and hopeful patterns of thinking, a kind of optimistic cognitive flexibility. How people are able to re-goal, to move from a goal that they entered with and perhaps proceed through great adversity and a lot of emotional pain, but come out the other side investing in new hopes. And to sketch the outline of this model, this sort of re-goaling model, so that it might shed some light on some very practical implications of how we might counsel parents and work with families, not just at a given moment, but over time. All right, I'm going to call this decision-making study number 1 because we have another one, study number 2, which is a more elaborate cohort study. In this study, what we did basically in a prospective cohort manner had interviewed of 50 children, 73 parents on a baseline measure. And it was a combination of some psychological instruments along with in-depth interviews. We talked to them at great length about what it was like to make decisions for their children. And I'm going to focus here on some of the psychological measures that we had. And then we followed that cohort for 6 months, the children, more or less passively. We were just observing what was happening to them in terms of decision making. We did not re-interview the parents. That's decision-making 2, where we're actually doing much more follow-up with the parents. Here it was just what happened to the children. We actually did publish these results in Archives of Pediatrics and Adolescent Medicine in 2010, so if you're interested, there's more you can spend time looking at that paper. But the effects of affect are really what this study is about. They talk about the iron triangle in healthcare of quality access and cost, and that's actually not, I don't think it's true, and it's not the true iron triangle. In all clinical encounters, every single one of them, this is the iron triangle. There are people who are thinking about what to do, they are relating to either providers in front of them, parents in front of them, and even if nobody's in front of them, they're relating through their history of prior encounters. And all of that is stirring up emotions. Their thoughts about what's going on for their child, their thoughts about what's going on for this patient, their thoughts about the other person they're having the transaction with. And this nexus of these 3 factors have to be understood together. Too much of psychological research is done with undergrads in college classes where they're not caught up in an intense situation with other people and their emotions are not supercharged. In clinical care, though, this is the iron triangle that we have to deal with. One of the measures we used for our parents, the hospital anxiety depression scale, has both a depression and anxiety scale. Our parents compared to patients with spinal injury, community adults, cardiac disease, and cancer, you can see that our parents endorse a high level of depressed symptomatology and an almost equally high level of anxiety. In fact, this work has really primed me to think that we are missing, with all the attention paid to depression, we're missing all the anxiety that's out there in the world, both amongst our parents who have very sick kids and even some of the not so sick kids. If you look at their positive and negative affect, which is the PANIS scale, again, very well validated, used in many different studies, these parents completely endorsed that over the last week they had felt a lot of negative emotion. Not surprising. And lots of positive emotion. Okay. Now, I usually scan the room when I put this up because I see some people nodding, and then I see other people having a quizzical look on their face of what's up with that. These are parents of children who are receiving pediatric palliative care, and they have a lot of positive feelings that they have had in the last week. And I think this is the first insight that I want to really try to put out there, is that this is the reality, that they love their child deeply, they are intensely proud of their child. Every step of progress that the child may make is something to celebrate. And that when we walk into the room to do a palliative care consult, we have to actually balance both the negative feelings and the positive feelings that are in the room. I used to think that positive and negative affect were like a dial that went from one extreme, very positive, smoothly to another extreme of a lot of negative. And that's not the way it works. It may, in our general life where the dials aren't set that high, that they offset, but it's actually more like treble and bass. You can turn both of them, like Spinal Tap said, you can turn both of them way up to 11. Okay? That was the volume, but I like to get my references correct. But you know the point, that they're independent. And actually, you see this when you are dealing with extreme, emotionally wrought situations about people that you love and care for. there often are both extreme emotions on the positive and the negative side of the equation. And both have to be respected. If they're not, parents pick up on that very quickly. And they often complain about the fact that the provider, the clinician, was all about doom and gloom. You don't have to be Pollyannish and only be about the positive, but you need to have that in balance. This is true at the individual level. So for any one of our parents, we had a positive score and a negative score. This diagram sort of connects them with a vertical line. So you can see that amongst those, and for the first time I'm going to introduce what happened as we followed the children up. So of the parents of the children, 43 did not have a limit of intervention order when we started. But by the end of the study, 19 did. So what we really were looking at was what accounts for subsequent limit of intervention orders. You might call them DNRs. They become so expansive now. It's not just about resuscitation. It can be about withholding antibiotics. It can be about not going back to the hospital at all. Most of these were classic DNR orders, but a couple of them are about more broad scope of we're not going to do that anymore. Here are the people who would go on after the baseline and enact a DNR, a limit of intervention order. You'll notice right away that the people who did not do that had positive scores that were typically greater than their negative scores. The positive here much higher at a group level than the negative. Amongst the parents who actually subsequently put in a DNR order, it's much more neck and neck, evenly balanced. We'll come back to that in a minute. We also needed to know, to the degree we could, how parents were perceiving the trajectory. When I talk to residents about patient care, taking care of kids in the hospital, I often ask them, your assessment is the child the same, getting better, or getting worse? And we wanted to try to get that general sense of, over the last year, did the parents perceive that the child was getting better, staying the same, or getting worse over time? So we asked them, we know your child has conditions that may make it difficult for them to have all the health you would want them to have, but imagine them in the best health you could imagine. Let's say that's a 10, and the worst is a 0. What is their health today, a week ago, a month ago, 6 months ago, a year ago? We're trying to get a sense of what's been happening over time. It's a very subjective measure, but I have no problem with that because the decision to actually enact a DNR, limit of intervention order, isn't a part, an outgrowth of how people are perceiving the situation subjectively. There may be objective data behind it, but this is what they think is going on. I call these the spaghetti plots. People on my team like to make fun of me for coming up with graphs like this. But the one point to take away from this is you've got one patient here who has a pattern where it starts off pretty good, gets even better, gets terrible, gets better, gets terrible again. This kind of crisis mode that so many of our parents have to deal with, where it's not what people had hoped palliative care would be all about, where there was a predictable slope and decline and you could see the edge of the cliff coming, and that it would be inevitable. Our children, I think, more often than not, particularly with neurologic conditions and even with many oncologic conditions or other things that may follow a predictable pattern, they live in a fragile state of health, where a little cold can become a crisis, where any little illness, any breeze actually can topple them over. And because we are good at what we do in the hospital, they can actually then recover from that. And this puts great pressure on the family as well as the providers to try to figure out, is this it? Is this the final illness? In total, this group, though, you can see that there is an overall downward slope if you look at what has happened over time that is less steep than the slope of the parents who subsequently put in a limit of intervention order. So basically what the two groups are starting to show is that they have different degrees of affect, more negative affect in this group and a little bit less positive, and a sense that the slope, the degree to which the child is getting ill over time, is steeper. So what's the relationship as we start to build up to a model between the illness trajectory, positive affect, negative affect, and whether they put in a limit of intervention order? Analyze singly, and I don't think that this is the proper way to do it, but it helps us to sort of understand where we're going to wind up, because our mind works with all of these things affecting us simultaneously. But we take it one at a time. Thoughts about the illness trajectory. If you thought it was going down more, you were more likely to have put in a limit of intervention order. I think that makes sense to everybody. My child is getting sicker. And maybe time that we rethink what we're doing. Positive affect actually put the brakes on doing that. I'm feeling good. Why would we change? The more I have positive affect, it sort of wants us to maintain the status quo. The negative affect actually is another strong driver like the illness thoughts. This situation is terrible. I don't just think it, I feel it in my gut. The work here, and this would be the second insight that I've taken away from this, not just that positive and negative are both present, but I used to think when I was a house staff member that part of my job was to try to assuage feelings of negative affect. And I still have that. I would love that Mason and children like that didn't have their problems. But one of the worst things I could do for anybody is say, I hope you have no pain. And then I would come back and see you a year later, and you might be in a wheelchair because you've lost the ability to feel pain in your feet. And you have suffered injury because you don't have any feedback that this is a dangerous situation. It may just be that I need to shift my weight, but if you become anesthetic to physical pain, we know the problems that causes. And the same, to a slight degree, is true about negative affect. Negative affect is one of the great motivators for life change. For people who are, it's not been studied as much as I had hoped it would be, but in people who are thinking about mid-career changes, who are ruminating about whether it's time to make a career change, or ruminating about a relationship that's not working for them. Negative affect is a motivator to say, I can tell in my gut that this is not the situation I want it to be, and to make a change. So, midway through this talk, I would say that one of the things I think we can see quite clearly is that when you walk into the room, even a room like the conference I was having with Mason's parents, and there are such palpable negative feelings, there's also, at the same time, a reservoir, most likely, of positive affect. And part of the mystery, as it becomes a mechanism, is how do you tap into that and allow it to have some direction where it can flow? It can go somewhere. It's not stymied. And that the management of these polyvalent, both positive and negative emotions, is one of the real tricks of doing palliative care right. The art of it is actually being able to walk in not Pollyannish and ignoring the gravity of what's going on. Parents want people to be straightforward with them about how difficult, sad, scary, angry they may feel. And at the same time be able to work with the positive feelings they have and give them a sense of where can that go, which leads us to hope. Now, in Western culture, there's really no good way to define hope that everybody would agree with. It starts out all the way back with a very mixed legacy. If you look at the myth of Pandora and her jar, it's not clear whether hope is all good. In fact, it's the last of the vices to be loosed upon the world. Is it false hope? And when I started to do this work, I was actually counseled by several people, don't look at hope. Hope is, quote, the enemy. And I think they think of it as false hope, as something that leads people astray. It's not reality. In fact, hope is so broadly defined in our culture, you can buy it over the internet. And I can't personally attest to this, but I have seen some of it in our household. I guess I should have declared that in my CME disclosure. So the hope definition that I'm going to work with is one that was put forward by psychologist Rick Snyder, formerly at the University of Kansas. And Rick had the following idea. And this is quite different than hope is sort of a sense, an inner sense of, I'm hopeful. It's not a feeling. This is actually how one can create that feeling. It's a trait. It's a set of psychological attributes that people might have that means that in a given day, a given week, and into the future, if I were to walk up to you and sort of had a hope thermometer, people who do well on this scale are more likely to have a higher score of a sense of hopefulness. Right? but it's not the feeling itself. It's the pathway to it. And what Rick thought was that people had hope if they had a goal. And he didn't spend as much time on this, and I'm going to come back to this, but they had to have a goal, and if they had pathway and agency thoughts, let me describe what that is. Pathway thoughts, let's say that for some reason, in the middle of this talk, I felt like I need to get out of here. Maybe I just having a panic attack, need to go to the bathroom, get a cup of coffee, whatever. I need to leave the room. Right? A little awkward. But there are different ways to do it. One is I could walk out that door. I see the two doors here. There are no windows, but there are these ventilation ducts. And if I was a good James Bond type of character, I could get up in there and climb out of here. Right? Those are different pathways. And it's actually interesting to see that people can generate. Some people are very quick at generating many, many pathways to solve a problem, lateral thinking. But then there would be the other problem. Am I the kind of person who could do that? Agency, self-efficacy. Am I the kind of person who could, A, walk up the stairs? Yes, I've done that a million times. But could I leave the room? That would be incredibly awkward for me. But could I do it? Would I ever have the guts to actually climb into a ventilation system? Probably not. So we're constantly looking at a variety of pathways towards our goals and assessing not just are they feasible, but are they feasible for me? Right? So one of the things I'm going to put out there is pediatric palliative care is about giving families pathways to their goals and helping them feel like they have agency, that they are capable of actually pursuing those pathways. If you look at the scale that Rick had created and look at our parents, we had done it previously. I had I had done a study of our nursing staff at CHOP to sort of get a sense of where they were in hopeful patterns of thinking. Our nurses are right here. So you can see that our parents have this resource, this hopeful patterns of thinking, agency and pathway thoughts, at the same level that you would expect our nurses to have. Now, it turns out if you are sending your kid to college, you want to go to college, not more college. More college, not as hopeful. But the point is that this is sort of the norm, that you see that there are a range here, and our parents, this does not mean at that moment they felt hopeful, but they have this capacity. So here's the question that motivated the entire study, because we had written the grant around this. Were parents with higher levels of hopeful thinking more or less likely to initiate a limit of intervention order? Now, the standard tact is that we are not allowed to actually give parents bad news because they'll take away their hope. I'm on the warpath against that notion. It is deeply disingenuous to the parents, and it, in fact, I don't think works with how hope and hopes actually work. The parents that we had, when you do it as an appropriate adjusted model for what's going on in their head, the illness trajectory is still, the steeper the decline, the more likely they are to have done it, but to a non-significant degree. Their positive affect, if anything, has become a stronger break. The more they feel good about a situation, the more likely they are to stick with the status quo. And we know that that is true about positive affect in a number of psychological experiments. If you feel good, you become risk averse, you don't move. Negative affect is now doing what we had seen before. It's pushing you towards it. This doesn't feel right. It's time to make a change. But the strongest predictor is that the higher they had levels of hopeful patterns of thinking, the more likely they were to put in a limit of intervention order. I think the reasons for this require us to go back to think about what is it that they're actually doing when they make these decisions, and revisiting our decision-making model. When people start out their journey, like Mason's family did, they have curative goals. Very little work in psychology has been done about what I'm going to call re-goaling, the concept that you start out with one goal and then you have to at some point let it go. It's sort of not American ethos to think about quitting, but to quit a goal, to let it go to the back burner and move on to something else. I mean, never mind, we do it all the time, It's just something that has not come under a lot of scrutiny. At some point for our families, they may have shifted to other non-curative goals that may have included the goal of what I typically talk with parents about now is protecting their child against things that might happen to them given how sick they are in a place like this, because the default is to do cardiopulmonary resuscitation. But we may not think that that's the best thing to do, and we may need to protect your child from having that happen. For them to feel that that is an appropriate goal to actually shift from cure to other ways of protecting and promoting the well-being of their child in terms that they never would have thought of when they entered the hospital, they need to re-goal. To do that, they're going to have to critique how well is the current goal going? How are we doing? And one of the things that we're seeing is the positive and negative affect help you critique that goal, along with your thoughts. As I often say, parents don't just think their way to the right decision, they have to feel their way to the right decision. And for all of us in the room who are parents, we know if there's something really important for our kids, we need to feel that it's the right decision as well as have thought our way there. At the same time, nature abhors a vacuum, and so do most people, a goal vacuum, that they need to know what are we moving towards. When Mason's family walked into that room, they had a goal vacuum. They didn't know what they were going to try to do. They just had the negative affect. They had plenty of positive affect, but the negative affect was given free rein because they had nowhere to go with their positive affect. Here are the building blocks of the negative affect, positive affect, thoughts about the child's illness trajectory, and patterns of hopeful thinking. Now, you're welcome to laugh when I show you this. It's a very busy model, and again, people on my team love to make fun of me. But the point is, if you actually look at, is there any evidence that negative affect actually helps you critique and supplant a current goal? You can quickly identify in the psychology literature, admittedly often about college undergrads, but occasionally about people who are considering divorce, or thinking about a mid-career change, or thinking about what kind of therapy to pursue for their chronic illness. You can find things like goal appraisal and rumination, a paper that actually talked about mid-career choices and people ruminating, becoming very negative about how this is not working and before they decide to shift career. And that absent that negative affect, they don't spend the emotional effort of actually being able to jump the rails, if you will. And that being sad actually slows us down and makes us much more critical. If I was trying to sell you real estate in Brooklyn Bridge, I'm going to try to make you feel happy. Because if I make people feel happy, they will be much easier to scam. As soon as you start to have doubts and are taking a step back, you become much more critical about the literature you're reading or facts that are being presented to you. Much more likely to say, I'm not so sure this is working. Emotional disclosure also allows, if you're able to talk about how you feel and the sadness that you feel, of being able to potentially think this goal may not be working well. On the positive side, it's a little bit more of a mixed bag, what the literature would say. I've mentioned that there is this clear data that the more you feel good, you don't fold. Anybody who plays cards knows you got a good hand, you feel it. And you're not about to give up the goal of winning. But if you start to feel badly, you're more likely to think, well, maybe I should fold. This risk aversion, this not wanting to potentially lose is the other angle of that you basically will not take a change because that exposes you to potential risk if you're feeling good. At the same time, the positive psychology literature has talked at great length about how we need to have some degree of positive feelings to be able to be creative. That you want a little bit of dopamine, if you will, a little bit of a positive high, to be able to have that insight, well, maybe we could try that. And once you start to have that kind of positive breath, you can broaden your field of view, broaden the options you're working with, broaden your pathways, and potentially build on that and create a new goal. This, to me, is the model that we should be working with as we think about the journey that parents are taking, as they try to actually understand how they go from curative goals. And it does not need to even be in the palliative care arena. This can be for any chronic illness that's simply not going to go away. How do we start to understand what it means to live with and adapt to the challenges that it's going to put in front of the child and the family? All right. Is this all that we should be talking about? I've mentioned that we're doing a second study called Decisionmaking 2, and I want to give you a little bit of data about that. One of the things that we've become interested in is what parents believe they need to do to be a good parent on their own terms. So we come up to families and say, as part of this, we'd like to know what you think you need to do to be a good parent, the best parent you could be for your child. You can tell us. Tell us what you think you need to do. And with Pam Hinds, my wonderful colleague now at DC Children's, we came up with an item pool of things the parents have said: advocating for the child, focusing on having as long a life as possible, comfort, health, quality of life, spiritual well-being, for you yourself as a parent to keep a positive outlook or a realistic outlook, to make informed medical decisions, to make sure that the child feels loved, to put the child's needs above your own, or to stay at the child's side. Now, at this point in our study, we have data from about 130, I'll show you the slide in a minute, parents. And we've actually been able to get them to rank order these, and we did it through something called a discrete choice experiment. So it's not overwhelming. We break it down so that they're not said, okay, you have to rank order all of these. It's much more item by item. They can figure out where it goes. Which one of these is the top one? Top 1, 2. Putting my child's needs above my own. Other? What's that? Keeping that positive outlook. Making sure my child feels loved. Okay, so as I've started to share this data with audiences, one of the things that becomes clear is that parents are different. You sort of may want to think about using this as a question. This is really my pitch. It's a simple question. As I'm taking care of your child and I'm trying to think of how to help you, it will help me to do that if you can tell me what do you think you need to be doing here at the bedside or for your child to be the best parent? Because the parents are thinking this. Trust me, they are pondering it. Maybe not explicitly, but they are worrying a lot about that. Well, it turns out, as a group, the number one item, and this is scaled so that this all sums to 100, 15 points here for making sure my child feels loved. And that the way the scaling is done, that this is roughly twice as important as putting my child's needs above my own for the whole group of parents. So everything that people said is right for some parents. But in mass, the number one issue is to make sure that my child feels loved. Now, one of the things I like to say when I'm wearing my medical ethics side of the hat is we've all read the textbooks of Beauchamp and Childress and the principal approach, and we remember the chapter in the textbook on love. I'm looking at Doug and Ben here. And people stare at me like, no, I don't remember that chapter because it's not in it. Okay? Part of what I think we need to come to grips with is we actually don't really know what this even means. And yet it's the number one true north that is guiding what parents say they need to do to be a good parent for their child. What does it mean to let your child know that they are loved? How do we put that into action? What are the pathways to accomplish that? Okay. This starts to pivot then from the mechanism that I've outlined back to what I take to almost be a bit of a mystery, this love issue. When we've looked at all of the transcripts of the parents in Decision-Making 1, it was admittedly about decision-making. So that's the number one theme that comes up, and this is a wordle where all of the words and themes are proportionate in size to the number of times that they were used. But you see that the number two most common endorsed theme is feelings. And this aspect of what it feels to deal with a positive and negative affect and to really love their child is of paramount importance to these parents. And then finally, I realized I should really read through to the end of Dante's journey. We're at the end of the Commedia, so he's been through hell, purgatory, and he's now up in paradise. And he writes that high fantasy lost power and here broke off, yet as a wheel moves smoothly, free from jars, my will and my desire were turned by love, the love that moves the sun and the stars. What I think parents are doing is actually using their sense of duties to love their child, to put their child's needs above their own, to keep a positive outlook. All of those things are endorsed. And they basically serve as a filter as to what goals are admittable, that can be admitted into consideration. There are certain goals that simply you're not allowed to even contemplate, because to do that you'd be violating your parental duty. All right? Parents often say, well, there was no decision to make, or we can't even talk about it. We can't even consider that. That's because of the role that parental duty has as a filter to sort of think about what goals are allowed to be admitted. And that's part of why entering into that dialogue with the family, what do you need to do to be a good parent, opens up ways of actually thinking through with them what are some actions, some goals that actually may be consistent with their goals and their sense of duty, but they just hadn't really thought it all the way through. What this leads to diagrammatically is, I guess before we have patient-centered care, what do we have before patient-centered care? MD-centered care, but whatever we had, in the 1990s, we started to really focus on how to be more patient-centered, and then realized that we need to get the family involved. And we've now shifted to a language of family-centered care, which I don't want to take up too much time here, but I think is losing sight of the fact that really what we are is patient-centered and parent-centered when I'm taking care of the parent, and sibling-centered, but they're potentially separable individuals, and I need to take care of them as individuals, not as a family. Like we walk into a shared room, two people in it, we don't say we have room-centered care. Like we'd be offended if we blended two individual patients together because their needs may not be the same. And we've seen in some families that the needs are not actually the same. So I think we have to take a step back and talk about patient-centered and not just family-informed, where we're trying to get the family members to understand. We're talking to them so that they can see the patient the same way we do, although that is often something we lapse into. What we really need to do is have intense conversations with families that, by the way, don't take hours and hours of time. Once you know what you're going for, I can run family meetings usually quicker than other people do, because we sort of cut to the chase fast, of talking about these deeper issues with them and exchanging information so that as I'm looking at the patient, I understand how they're looking at the patient, and we can influence each other as we try to think of what's the best thing to do. And it's not just parents. If you look at what Avidus Donabedian, the father of quality improvement, structure, process, outcomes, said, as he was interviewed, he knew his life was drawing to a close. And this may be perhaps read as him being maudlin, but I don't think it is. I think there's a deeper insight here we need to come to grips with, where he said, ultimately, the secret of quality is love. Ooh, that's too sentimental. And we sort of back away from it. But I am very aware, as I do ethics work in our hospital, we think about policies of how do you motivate people to actually do the right thing. If I create more rules and more regulations, I am taking away your moral agency. I'm telling you, it's not a choice for you anymore. You'll just get in trouble if you don't do it this way. As opposed to empowering you to actually influence the world through your moral agency and grow that capacity. And grow your capacity to actually be invested in the well-being of your patients, in the well-being of these families, to a degree that you actually are motivated to go the extra mile for patient safety or quality. All right. As I end here, I want to just go through some of the clinical implications of what I think this means. First, I've tried to demonstrate that some of the questions one might ask to get into these conversations are very simple. From your point of view, can you tell me what's going on here? To help open up the gateway that the parents can talk about what they're thinking. And then the question that I used with Mason's family. It will help me take better care of your child if you can tell me, given what he's up against, what are you hoping for? And expect that the first answer may be for a miracle, maybe for that this is a bad dream. This is very common. And I think obligatory, because parental duty tells you a good parent is always hoping for the best. And I think that's completely understandable, and it's not to be argued with. Do not stop when well, we've talked about the fact that the cancers come back, and don't you know that? No, that misses the point. It's a coping mechanism. When parents say, I'm hoping for this, all you need to do is hear it. And I often say, I wish that could be true. To sort of join with them in what really does feel like an earnest, I do wish that was possible. What else are you hoping for? And wait to hear what they say, because the very next thing they say, when they make it abundantly clear that they're not in denial, that they completely understand what's going on. Years ago, I was talking to a 9-year-old girl who had relapsed cancer. And I asked her, with her mom sitting next to her, what are you hoping for? And the girl looked at me and said, I'm hoping the cancer goes away. And I took a deep breath and said, in my mind, shit. Because that's exactly what we're afraid of, because I would love to be able to give this beautiful child that. And then I realized it's not about me, it's about her. What else are you hoping for? She said, I'm hoping I don't die too soon. And I'm hoping I can go home and play with my sister. My point is that often the first thing that people say is not the last thing they will say if you give them a chance. And that those last things that they say, the next thing, in Mason's story, I could not do anything about the bad dream, but we could turn off the lab testing immediately. We could stop the goal of him having to gain weight so that the team was unencumbered by needing to meet that discharge criteria, and we were able to get him home. That those were the hopes that became the new goals, that they re-goaled by the time that meeting was over, and had new targets that their positive affect could flow toward. In doing this, there's some other aspects of the psychology that actually helps. And we know this from the literature about heuristics and biases and things like that, but we're constantly framing complex situations. I remember when I was a second-year resident upstairs in the IICU, it used to be, I guess, right up here, and there was a child who was skirting, failing mechanical ventilation, may need to go on the oscillator, had a bad heart, and actually talking to those parents. I've seen loving parents at this juncture decide the best way to love their child is to escalate and let's go on the fancier ventilator and actually be able to do that. I've also seen loving parents decide that now's the time to have the family come in and we can switch the ventilation setup so that they can hold the child. And they said, we need to think about this, and then they opted to actually hold their child after months of not being able to do that. But that kind of framing effect of a symmetric, just simply saying, I've seen loving parents do both. I'm working with parental duties. It's a way of doing that. It allows them to actually be able to think of re-goaling. And that tagline of given what your child is up against allows people to think about the anchor against which they're considering their hopes. What else are you hoping for? On pathway thoughts, this symmetric unpacking, too many times we hear lengthy descriptions of what escalation will look like and not enough about what it would mean to actually pursue a palliative pathway. And because that's not unpacked enough and they've never seen it done, it's not really available to them. They need to actually have enough detailing, and this is where palliative consults can be very helpful, just to sketch out what that will look like, so that they can actually be able to imagine what it would feel like to go that route. And throughout this, and this is as I'm coming to the end here, that parents are trying to grapple with what it will mean for them to have made these choices and what it will mean to be loving parents in a situation that is so threatening in terms of not just the threat to the child, but how can we ever make sense of what has happened here? It's like Beethoven's Grosse Fugue, the great movement that he wrote for one of his string quartets. It was too confusing. His colleagues said, Louis, you got to get rid of that. You can't have that. So it's its own separate piece of art now and needs to be listened to over and over again before people can begin to understand how is that music and not just cacophony. And what we're doing as parents confront their own cacophony of experiences, we're starting to talk with them in these conversations, with these questions, to think about how they make sense. And in doing that, we enter into a kind of co-authorship with them, We're essentially helping them, as colleagues might, to think of how they want to write this story. Which leads to the deeper questions that I'm going to end on. If we do that, what separates the management of hope from manipulation? I think this is a profound question that we all have to think about, not just those of us in palliative care, but all of the, and I understand the needs for hospitals to have a business plan and marketing and advertising, and all of medicine to do that. But I do put out there, I think sometimes, I hope I catch nobody off guard here, we overhype, to put it mildly. And that leads to problems where we're using positive and negative affect, and people outside of this hospital are using it to a number of different ends. How do we make sure that that stays within the bounds of ethically appropriate management of hope? And what role do we have to actually challenge some of the cultural tropes of, let's say, the Lance Armstrong Live Strong bracelet? I've had too many teenage boys and girls wonder how they failed their fight against cancer, of basically saying that's not the way I ever have seen this, and help them to reimagine what it means for them to have had their experience. And then lastly, where does love figure into this? Can we talk about love and not be so self-critical that it's just maudlin and sentimental? Because it's clearly an agent that is having an effect. How do we study it? How do we come to understand what it's doing? And how do we work with it? I'll end then by saying I hope it's been clear that hope and hopeful patterns of thinking are powerful influences on decision-making, and in unexpected ways. Nobody would have expected before we did our study that parents with higher levels of hope would be more likely to have put in a DNR order. And that we need to develop and test techniques that will enhance our ability to communicate and collaborate and partner effectively with parents, both regarding not just their thoughts, but also how they're feeling. Thank you.
That was wonderful, Chris. Thank you so much. Dr. Feudtner will be giving a special bioethics seminar at the Research Building 1 at 3:30 today in room 606 for those of you that are interested. We might have time for one question. Dr. Neff, you certainly deserve that honor.
Chris, I expected a beautiful talk and was by no means disappointed. It was wonderful. I got stuck, though, on something, and I've been stuck on this for your whole talk. And that is, I started out thinking of the palliative care as a separate service and then the other as another service, and the palliative care as a rescuer. And then when you went into this whole issue of positive and negative affect, I realized how much impact physicians and caregivers have on creating either the positive or negative impact at the very, very first onset when the families are most vulnerable and they're given bad news. And so then my thoughts were that this is a continuum. This isn't a service. This is how we all become skilled into it. So how do we do that? How do we get this information that you have down to the level at the earliest training so we move into these situations with the kind of heightened sensitivity that you have?
I agree with you. Let me unstuck you. I mean, I backed into palliative care, starting out with the care of the chronically ill child and family, and then realizing some of them needed palliative care. And in the last decade, we've grown up a subspecialty. But with Maggie and others, where we're trying to exert some sense of where the field is going, we talk about primary level of competence, which is very basic. Everybody should be able to deliver bad news because we won't give it. We often come in after, like Mason's case, after the news has been given. And that everybody should be able to have basic, and not basic in like simple, but the beginning conversations, intermediate conversations, and maybe all the way through to the most difficult conversations can still be with the primary service, the primary providers. What the team does is it augments and gives greater strength and greater ability to problem solve and think laterally. If we've done this 100 times, there may be other options. I think in terms of training, this is what my current focus is on, actually how to help people with emotional handling skills and the interpersonal aspects of communication, which I think is issues that are going to require new techniques of teaching that we don't currently have.
Well, thank you very much. We're very proud of you being an alum. That's all. I really enjoyed reading Groupman's Anatomy of Hope.
Yeah.
That's really, do you think that's a good